Thank you, Mr. Chairman. The thought of performing a total knee replacement for the fused or ankylosed knee can intimidate, and perhaps for good reasons. However, the TKA is a rewarding procedure, provided we anticipate the technical challenges and learn to expect a little less than what we have got accustomed to with our standard total knee replacement. The indication for surgery is simply to restore function. The ability to dress, sit, walk with a painless knee represents huge gains for patients with multiple joint affectation. The outcome is hugely dependent on implant choice, your surgical technique, your ability to avoid complications, and not least of all, on pathology. In surgically fused knee, the status of your quadricep muscle determines the feasibility of a total knee replacement, whereas in post-septic knee, scarring and the risk of reactivation of the infection are determinants. And for inflammatory arthropathy, the status of the disease, the status of the other joints are influential. This presentation is mainly about inflammatory ankylosis. I'll try to identify the values, risks, and challenges of total knee replacement and discuss my personal technique. There are not a lot in the literature on this subject, and my experience tallies with that of Bay and Kim. The general consensus is that the vast majority of patients will be pleased with the operation. The outcome, however, is a little less satisfactory compared with the standard total knee replacement. You may expect a little less pain relief. Range of motion will be less than your standard total knee, ranging from 80 to 100 degrees, and you can expect up to 50 points gain in your knee score. There are, however, no long-term studies to tell us about the durability of fixation. But these patients are low-demand patients, and for them, just to be able to walk, sit, lie, dress, represent good gains. For ankylosing spondylitis, there's usually affectation of hip, besides the knee, and oftentimes the ankle. And thinking about the sequence of surgery is important. There are a number of options. You can do all four joints together. You can do hip and knee on one side first and then go on to the other side at another time. My preferred sequence is to do ipsilateral hip and knee. And positioning of the patient is something that requires some thinking. The technical challenges are greatest with major flexion deformity. The skin is usually thin and vulnerable. The bone is usually very osteoporotic, and there are a variety of soft tissue abnormalities ranging from simple contracture to these soft tissue elements being bound down to bone and occasionally even ossified. Here's an example of a 36-year-old male with ankylosing spondylitis. He had both hips replaced by a local surgeon, and in this short early experience, the operations were done mainly in China and some in India and Hong Kong. I had no control over the sequence of the operation or the choice of prosthesis. And in those days, I did not do a routine tibial tubercle osteotomy, which I do now. In a very brief review of the first 22 cases I did, the average range of motion was about 80 degrees, and the knee score improvement about 50. Wound dehiscence was the most common complication, with 2 cases of superficial infection, 1 of deep infection, and 1 of transient peroneal palsy. Now, the operation is made easier with a frontal approach using a routine tibial tubercle osteotomy, and the recognition that even with comprehensive soft tissue release, you are unlikely to create enough space to accommodate your prosthesis. So bone resection of some degree is necessary to create the space. And I would generally secure the extension space before the flexion space, then doing a final soft tissue balancing. And I have a very low threshold for use of constrained prosthesis. The incision is usually longer than average so that you do not put stress to the skin, and there's usually need to lateralize the skin flap so it's easier to get around to deal with your ligaments. You can get away with a rectal snip or a partial V-bioplasty in some cases, but I recommend a routine tibial-typical osteotomy. You should need to protect the patellar tendon. The bone is usually soft and it's easy to peel off the patellar tendon, but if you're doing a tibial-typical osteotomy, that's not a problem. The tibial-typical osteotomy is a great facility, helps you protect the tendon, allows you to adjust the patellar height, and most of all, allow you to do the takedown from a full frontal approach. The collateral ligaments are variably stuck to bone and capsule, and you should need to release it. And when you do release the collateral ligament, I normally do it subperiosteally. The quadriceps tendon is almost always stuck to the femur, and that needs to be free. And you see variable degrees of fatty and fibrous substitution. You should need to exercise most of this. Now, the humble spacer block is a great instrument for this operation. It's simple and it's very useful. The patella may be ankylosed to the femur, and you need to free that with an osteotomy, ensuring that you take a generous amount of remnant patella. And this is very quickly, this is a sequence of the operation using a spacer block, identifying the fibular head to mark your joint line. You take off a segment before approaching the posterior cortex. Once you secure your extension space, you flex your knees, do your posterior capsule release, free your collateral ligaments, then select an appropriate tibial stem. Using the trowel tibia, you can then refashion your tibial cut. Usually, it is preferable to impact the bone, osteoporotic bone, rather than use an osteotome or saw. And you go about refashioning your femur with your cutting block set at 0 degrees. And again, I have a low threshold for stem extension. Once again, the spacer block is useful for judging how much bone you take to create your flexion space. In some cases will require that you do hamstring releases, which you can do percutaneously, and in some cases a quadriceps plasty. I normally do a 2-plane quadriceps release. Major flexion deformity is a greater challenge, and there are 2 ways about it. You can first correct the flexion deformity, excising a bone wedge, and then go about creating your extension and flexion space, or you can do a standard tibial resection before correcting the deformity. This is the first method, taking a wedge of bone, correcting your flexion deformity, then you're creating your spaces. Or you can do a standard tibial osteotomy and then go about correcting your deformity. Here's a case from Hong Kong, and with a tibial-typical osteotomy and a semi-constrained prosthesis. One of the challenges is to maintain the extension that you have obtained, and quite oftentimes I will use an extension spleen for a few weeks. It's a satisfying operation. All patients gain with regards to ambulation and posture. The majority will still require some walking aids, mainly because of other joint afflicting. Thank you very much.